Hello, everybody. Harry Hockheiser here, Director of the MIDAS Coordination Center, and appreciate you coming on this off-schedule webinar slot for Sherrie Zia, who was ill a little while ago when she was scheduled to speak, so we've rescheduled her. Dr. Zia is a postdoctoral research fellow in infectious disease epidemiology in the Department of Biostats, Epi, and Informatics at the University of Pennsylvania, and I'm looking over Dr. Zia's Google Scholar page and seeing all sorts of interesting things here about work on electronic medical records and some environmental things and some COVID things. And I'm really sort of fascinated because I think this might be the first time we've had a speaker who's published on bed bugs. And so I might have to take a look at that paper a little bit later. But anyway, I want to say thanks to Dr. Zia for being willing to join us. And I'll hand it over to you.
All right, thank you so much. Hi, everyone. Thanks for being here. Today, I'll be talking about a project where we incorporated queuing theory into a spatial optimization framework to improve mass vaccination programs. And I will say before I started my postdoc, I had no idea what queuing theory was. So I'm excited to use it in my research and hopefully talk to more people about why it's useful in these sort of public health contexts. And so that's the first slide. Why do we care about queuing? So we probably have all felt from recent lived experience with the COVID vaccine pandemic, or COVID pandemic, how important it is to expeditiously and equitably distribute vaccinations as a cornerstone of pandemic preparedness. However, if we are under-resourced or we're not thoughtful about the placement of our vaccination sites, what can result is the formation of long waiting lines or queues, which can impede vaccine uptake. And so here I'm showing a few photos of a queue formation at mass vaccination sites. This photo in the middle was taken right here in Philadelphia in February of 2021. And you can imagine how miserable it was waiting in the dead of winter to get your vaccines. And we care about queues not only because it's a miserable experience for the people who have to wait in them, but you can imagine being someone motivated enough to show up at a vaccination site to get your COVID vaccine, seeing this line that wraps around the block and decide, oh, I have too much going on today. I'm not going to get my vaccine after all. Or you might join the line even, but eventually you lose patience and you give up and you leave. So we care about queues because people who are otherwise motivated enough to get the vaccinations they need can be deterred if these wait times are too excessive. And this last photo is just to remind us that queue formation doesn't happen just outside of COVID vaccination sites. It happens in other sort of healthcare contexts as well, including this mass dog vaccination clinic against canine rabies in Tanzania. And canine rabies is actually the model system that I'll be talking about today. And you might know that rabies is a zoonotic viral disease affecting the central nervous system. And what's really scary about rabies is that although effective post-exposure prophylaxis is available, once clinical symptoms appear, it is virtually 100% fatal. And relevant to our talk today, domestic dogs are responsible for up to 99% of human cases. And if we look at the global picture for canine rabies, we can see that human deaths from canine rabies is highest in India, parts of East and Southeast Asia, as well as some parts of Africa. And if we look over here to the west of the Americas, the burden is relatively lower in this area, but that's not to say that it's not a problem in the Americas. There's been a significant reduction in human cases since the 1980s, thanks mostly to dog vaccinations. However, it's still endemic in a few different countries, shown here in black. Sporadic outbreaks continue to occur in these countries labeled in these brown dots. And in 2015, Brazil, Argentina, and Paraguay reported canine rabies for the first time. And that same year, canine rabies was reintroduced in the city of Arequipa, Peru. So this is a city that was previously declared free of canine rabies, and we saw a reintroduction in 2015. And this is a photo from Arequipa. This is where our field site is located. It's a beautiful city of over 1 million human inhabitants, and it's located at the valley of a few just beautiful looking volcanoes. One of this is shown in the background here. And one important thing to note about Arequipa is about the dog ownership practices there. That in Arequipa, as in many parts of the world, owned dogs, so companion dogs, are allowed to roam freely for at least part of their time outside. And while they're free roaming, they're free to scavenge for trash in the water channels. They're interacting with other dogs, and sometimes they're getting into fights with other dogs. And that explains why, since that reemergence in 2015, this canine rabies has really become a full-blown epidemic in the city. We've had over 370 confirmed cases of canine rabies, and sadly, we not too long ago, last October, had our first confirmed case of human rabies. And the way that the city has been responding to this epidemic is through mass dog vaccination campaigns, because canine rabies is a vaccine preventable disease. And the way these vaccination campaigns, which I'll refer to as MDVCs, are conducted is that every year, people with their dogs, owners, bring their dogs on foot to fixed location vaccination sites. And they're bringing their dogs on foot because car ownership rates are low in Arequipa, and public transit is not reliable. And although the World Health Organization and the Pan American Health Organization recommends a sustained minimum 70 to 80% vaccination coverage, sustained yearly, to ensure herd immunity. And I say annually because the vaccines that are used in Peru are only good for 1 year. And despite this recommended threshold, the coverage estimates across Arequipa has fallen below that threshold. And that is an important objective of our group, is to increase participation in these vaccination campaigns. And to that end, other members of the lab conducted a post-MDVC survey to 6,000 households following the 2016 campaign. And they identified 3 important barriers to participation. Having young children in the household, being a recent immigrant to the city, and the last one, which will be the focus of this talk, is living far away from a vaccination site. And I think this figure shows well this relationship between distance to the closest vaccination site and the odds of vaccinating your dogs in these campaigns. These circles with the cross marks indicate locations of fixed location vaccination sites. And these maps are colored according to the odds of participating in the vaccination campaign. And you can see clusters of high participation rates close to the vaccination sites. So leveraging this information about this important relationship between proximity to a vaccination site and participation in the campaign, in previous work, we devised a data-driven strategy, a spatial optimization framework, to guide the placement of fixed location vaccination sites. And the objective in this initial work, that is still our objective in the work I'll present today, is we're trying to find the optimum 20 vaccination site locations out of these 70 candidate sites. And this number 20 is not random. It's based off of resource constraints in this area. This is how many vaccinators the Ministry of Health can allocate to this area. And this type of optimization problem is not new. There's a lot written about these facility location problems in the literature, which is a branch of operations research concerned with the optimal placement of facilities such as factories, warehouses, or in our case, vaccination sites, to minimize travel costs. So you might imagine that Amazon is very good at solving these kinds of problems. And there are some classic solutions to the facility location problems. They include the p-median algorithm, which aims to minimize the maximum distance traveled, and the p-center algorithm, which minimizes the average distance traveled. And in this initial work, we devised a p-probability algorithm that maximizes the sum of the expected probabilities of participation among all dog-owning households. And we were able to devise a p-probability algorithm because we had we fit a regression function to historic survey data to characterize the relationship between walking distance to the closest vaccination site and the probability of participating in the campaign. And I'll go into detail about our optimization algorithm when I talk about the main study that I'll present next, but I'll just present the results of this previous study. And what we did was we compared our optimized sites to sites that were actually used in 2016. And these sites are shown by these white triangles. And you might notice right away that these triangles are not very well distributed across our study area. The houses of our study area are these dots that are colored according to the probability of that household participating in the vaccination campaign as a function of their proximity to the closest vaccination site. And you can see what results from this poorly placed set of sites is you have these pockets of areas where participation is expected to be low. And our spatial optimization algorithm places sites in a more sort of evenly distributed way, and what results is fewer of these under-vaccinated pockets, and our expected vaccination coverage is expected to increase as a result. So that was sort of one of our main results from this study, but we were also curious to see what the distribution of workload across the selected sites looked like. And what I mean by workload is the number of dogs that are expected to arrive at each one of these sites. Because you can imagine if many dogs arrive at a single site, then you might overwhelm that single vaccinator working at the site, and you might have the formation of very long queues at that site. So our initial optimization algorithm, which doesn't account for this type of queue formation, did improve the evenness of the workload across sites, but it's still not perfect by any means. And we wondered if we might be able to come up with a queue aware or queue conscious algorithm that can factor queue formation into account. And so that was really the motivation of the study that I'll be presenting today. Our goal was to state it explicitly, was to develop and implement a queue-conscious algorithm that optimally places vaccination sites, that minimizes walking distance, but also factors in losses from queuing. So the outline for the study that I'll present is, first I'll start by presenting the queuing model that we used for the mass dog vaccination campaigns. Then I'll introduce our queue-conscious algorithm for MDVC site placement. And then I'll talk about our methods, our results, and then the sensitivity analysis at the end. So before I talk about our specific queuing model, I do want to introduce very quickly queuing models more generally. They come from queuing theory, which is a branch of applied probability that studies waiting lines or queues. And put sort of generally, queuing models represent how a customer population moves through a service center. So by service center, that could be a vaccination site. It could be people calling into a call center. It can be people waiting in line at Trader Joe's. And these models will capture the process of joining and waiting in line, getting service, or customers might leave the line due to lack of patience. So these processes are all captured by a queuing model. And these models are interested in studying specific performance metrics, like the average number of customers in queue, the average time a customer spends waiting. But the one that we're concerned about is the total customers served, or the total dogs vaccinated, because what we're ultimately interested in is maximizing our vaccination coverage. So now I'm ready to introduce our specific queuing model, and I'll go over this queuing model through the various processes that it captures. So first, you might imagine an owner brings their dog to a vaccination site, and as soon as they arrive, they're met with a decision point. They can either decide to join the queue, or they might decide that the queue is too long and they decide not to enter it because they just don't have the patience to wait in that line. And this first form of attrition is known as balking. Next, let's say that the owner does decide to join the queue. Now they're waiting in line, and while they're waiting, they're met with another decision point. They can continue to wait, or at any time, they might lose patience and exit the queue. And this form of attrition is called reneging. But let's say the owner waits it out, they get their dog vaccinated, and then once the dog gets vaccinated, they leave. So at this point, I want to point out that all of these processes are governed by rates. And I'll talk more about the arrival rate and the service rate in the next slide. But right now, I just want to talk briefly about these balking and reneging rates, these different attrition rates. And I'm giving them here in this sort of general functional form. But what I want to emphasize is that these balking and reneging rates are going to be a function of the number of dogs in the system. So the dog that's getting vaccinated plus all those dogs waiting in line. And in general, our balking and reneging rates, we're going to model them so that they increase with the queue length. And so the way that we'll try to mediate losses due to queuing across our vaccination sites is by mediating the queue lengths at these sites. And that's all ultimately what our optimization algorithm is going to try to do. But first, some assumptions. We're assuming that queuing at an MDVC site can be approximated by what's called an MM1 queuing system. So this is a type of very simple and well-studied queuing model. And we name queuing systems with a letter, and a number. And so this first letter M is going to stand for Markovian or memoryless, and it's going to refer to our arrival rate. We're going to assume that dogs arrive according to a Poisson process with rate lambda, meaning that the time between arrivals, those inter-arrival times, are memoryless or IID exponential. The second M is going to, again, refer to a memoryless process, but it's referring to our service rate. And we're assuming that the service time, or the time that it takes for a dog to get vaccinated once it moves to the front of the line, is going to be an IID exponential random variable with parameter mu equal to 1 over the average time it takes to get vaccinated. And finally, this number 1 refers to the fact that there's only one vaccinator per site, so that only one dog can get vaccinated at a time. And this is sort of the reality for our relatively resource constrained system. This is in contrast to if you got your COVID vaccine at a large convention center or a large stadium, you might then have been dealing with an MM13 system where you had 13 vaccinators working in parallel. The way that we model balking is by modifying this arrival rate lambda so that this effective arrival rate lambda n equals e to the negative alpha n over mu times lambda, where n, again, is the number of dogs in the queuing system, and alpha is our balking parameter. And as alpha increases, the overall balking propensity increases. So you can see here, as we increase the value of alpha for any given queue length, we're going to have an increase in our balking probability. And the way that we model reneging is by modifying our service rate mu so that it equals this exit rate mu sub n. And this exit rate is going to be composed of dogs who exit the system because they've gotten vaccinated, represented by this mu. And the second term is going to capture the dogs that leave the queue before they get vaccinated. So this is really our reneging rate, n-1 times beta. And beta is our reneging parameter. And for increasing values of beta, we're going to have an increased reneging propensity. And the last thing I'll say about this queuing model is that it's really a compartmental model. where we're keeping track of N, the number of dogs in the queuing system. And we have these transition rates that are governed by our arrival rates, our bulking propensity, and then our exit rates as we decrease from one compartment to another. It's from dogs either leaving the system because they've gotten vaccinated or because their owner has reneged and has left the queue before getting the vaccines. And I think it'd also be helpful to show some trials of our stochastic queuing model to get an even better handle on our queuing model. And in this first slide, I'm going to show trials from a scenario we have a low bulking and reneging propensity, so low values for alpha and beta. And I'm going to show trials from a low arrival rate, 15 dogs per hour, and a higher arrival rate of 30 dogs per hour. So in this initial draw from our stochastic simulation, each trial is going to simulate a single 4-hour day at a vaccination site. And up here, we're tracking the queue length over time, and we're also tracking the times that a vaccination, a bulking event, or reneging event occurs. And what we can take away from the situation where we have relatively few arrivals and a low bulking and reneging propensity is that we're going to have relatively few bulking and reneging events. And our queue lengths are going to stay relatively short because of that low arrival rate. In contrast, if we double our arrival rate, our queue lengths are going to get very long, and sometimes they're going to exceed 10 dogs in the line. And because our queue lengths are getting so long, we're also going to have more bulking and reneging. Because even though we have a relatively low propensity for bulking and reneging, when our queue lengths get too long, even in the system, people are going to decide that they don't want to join the queue or they want to leave. And that's ultimately going to impact the number of total arrivals that stay to get vaccinated. Now I'll show the same trials, but in a situation where there's a higher bulking and reneging propensity. So here in this first situation where we have relatively few arrivals, you'll see that now we have more bulking and reneging events, because even when the queues are short, in this situation, we're assuming that our population has low tolerance for queuing. So even with short lines, they're going to leave. And when we double our arrival rate, you're going to see how much more bulking and reneging events we have. And before, you'll remember that the queue lengths increase beyond 10 dogs in the line. Now our queue length is really capped because in this situation, our population is not tolerant to waiting in a long line. And we weren't just interested in building a stochastic model for our queuing system. We also wanted to derive some closed form expressions for the behavior of our queuing model. And I won't go over the derivation of this equation, but I'll go over sort of the highlights, where the expected number of dogs vaccinated per unit time at some vaccination site S is going to equal this first term, which captures the effective arrival rate, the rate that dogs join the queue after accounting for bulking, subtracted by the rate that dogs leave before getting vaccinated, or the reneging rate. And so with this expression for the vaccination rate at each site, we can then calculate the number of dogs vaccinated across all sites as this expression. We just added over all the different sites to get the expected number of dogs vaccinated. And this forms the objective function for our Q-conscious algorithm. And this is all great that we have this sort of tidy expression, but at this point we were concerned because this equation was derived under the assumption that the model has, or the system had reached equilibrium. And like I mentioned, the vaccination sites operate for only 4 hours per day. And so our question was whether the system can really reach equilibrium that quickly in just 4 hours. And in other words, we were wondering if our theoretical results would agree with our simulation, which better captures the dynamics of our system. And we were happy to see that our simulation results, which are shown, the median of 1,000 iterations is shown by these this red dotted line, which the iterations are run also over a range of arrival rates, and the interquartile range for those iterations are shown by this red shaded area. And you can see that there's good agreement between these simulation results and the results using the closed form expression I showed in the previous slide are shown by this black line. And this held true for both the low attrition scenario and a high attrition scenario. So with that, we were comfortable proceeding using the closed form expressions in our optimization algorithms. And now I'm ready to talk about our optimization algorithm for placing vaccination sites. We developed a hybrid recursive interchange genetic algorithm to optimize vaccination site placement. This first component, the recursive interchange component, is a simple algorithm that uses a swap one out strategy to iteratively improve upon a starting set of sites to arrive at a locally optimal solution. And the keyword here is locally optimal, because any given run is not guaranteed to give you the global optimum. And so we got around this problem using two strategies. One was that every time we ran the recursive interchange, we ran it 1,000 times to increase the number of solutions so that we can hopefully find the best one. And then the second strategy was we combined this recursive interchange with a genetic algorithm. And for those who aren't familiar, a genetic algorithm mimics a process of natural selection to introduce diversity through recombination and mutation. And what the genetic algorithm did in the context of our algorithm is it took the locally optimal solutions from this recursive interchange. It took them, it mated these solutions together, and it added some mutation to increase the diversity of this offspring set. And this offspring set was then fed back into the recursive interchange. And so our algorithm works by cycling between this recursive interchange and the genetic algorithm until 2 consecutive rounds of optimization does not lead to an improvement in the expected number of dogs vaccinated. So here's a picture showing the schematic of, this first round is just a recursive interchange. We run it over 1,000 iterations. Retain the best one to assess the stopping condition. We input these outputs into the genetic algorithm, increase the diversity, make these solutions together, and then introduce them back again into the recursive interchange. And then we just cycle through these 2 components until 2 consecutive rounds does not improve the solution in terms of the expected vaccination coverage. And then we were really interested in comparing the performance of our Q-conscious algorithm to an algorithm that's identical in every way, except that it doesn't account for queuing. And so in this slide, I just want to explain the differences between our Q-naive and Q-conscious algorithms. So under the hood, they look almost identical. They both look like that. They just differ in how they determine the expected number of dogs vaccinated, which is our objective function. So the expected number of dogs vaccinated is determined via 2 steps. And this first step is the same for both the Q-naive and Q-conscious algorithms. In this first step, the MDVC participation probability function, which was that regression function that I showed in a previous slide, that quantifies the relationship, the sort of decay in the probability of participating in the campaign as you live further and further away from a vaccination site. So we use that function to determine for a given configuration of vaccination sites, the number of dogs that are expected to arrive at each vaccination site. The difference is in this next step. The Q-naive algorithm sort of naively assumes that all the dogs that are arriving are going to stay to get vaccinated. So it simply sums across the number of arrivals to get at the expected number of dogs vaccinated. The Q-conscious algorithm is a little bit more sophisticated in that it transforms the number of dogs arriving. It transforms that for each site to an arrival rate. And the way it does that is by assuming that the arrivals are happening at a constant rate. And in one of our sensitivity analyses, we do test how sensitive our results are to that constant arrival rate assumption. But once it has that arrival rate calculated for all our different sites, then it uses that closed form expression to calculate the expected number of dogs that will stay to get vaccinated and the number of dogs that are expected to be lost to queuing attrition. So our methods, we placed the MDBC sites using the Q-conscious algorithm. So I'll call these our Q-conscious solutions under a low attrition scenario where we have low bulking and reneging parameters, and a high attrition scenarios where we have high bulking and reneging parameters. And when we do that, because we don't have empirically derived estimates for alpha and beta, so we chose values on the low and high range of what we thought was feasible. And we compared these low attrition and high attrition solutions to a Q-naive solution that we obtained via the Q-naive algorithm. And then we assess the performance of our sites placed in these different ways under the assumption of the attrition parameters actually being low or actually being high. So we know that it's unrealistic to assume that there's no attrition due to queuing. So we want to consider these two different scenarios where we have a low attrition setting or a high attrition setting to assess the performance of our solutions. And then we compared Q-conscious optimization to Q-naive optimization with respect to the spatial distribution of optimized sites, the distribution of arrivals and losses to attrition across sites, and the expected vaccination coverage. And then finally, we assess the sensitivity of our results to misspecification of the bulking and reneging parameters and the assumption of a constant arrival rate. So in this slide, I'm showing the Q-naive solutions and the Q-conscious solutions for the low attrition setting. So I'll just explain what we're looking at here. So the locations of the vaccination sites are shown by these white circles, and these white circles are scaled and labeled according to the expected number of dogs arriving at each one of these sites. And then the houses in the study area are colored according to their catchment. And what I mean by catchment is that, so all of these houses shown in this crimson color have this site as their closest vaccination site. So this forms a catchment. This area forms a catchment for that site. And so I'll highlight some of the key differences between these two solutions. We can see in the circled area, this area is a high population density area. And because it's a highly populous area, the Q-naive solution, there's many dogs that are expected to arrive, 400 or more dogs. And having this many arrivals is likely to result in the formation of long queues. And these dogs are expected to, or some of these dogs are expected to be lost due to queuing attrition. So the way that the Q-conscious algorithm deals with this is it simply adds an additional site to this area so that now you can more evenly distribute these arrivals across these 4 different sites. And a similar thing happens in this area where we have another highly populous area, which the Q-conscious algorithm deals with by adding an additional site. And to make up for the fact that it's adding 2 additional sites, the Q-conscious algorithm also removes sites in these less populous areas shown by these dotted black circles. Another way to view the distribution of the number of arrivals across our vaccination sites is through this histogram. So now every site is represented by a bar in this histogram, and the height is given by, or the height represents the number of dogs that are expected to arrive at each site. And so right away, you can see that the Q-conscious algorithm places sites in such a way that we have a more even distribution in the number of arrivals. And we can also split these bars up into not just who arrives, but of those arrivals, do they stay to get vaccinated or do they leave due to queuing? And so what might be, what kind of makes sense is as our bars get higher, as we have more arrivals, we then have more losses to queuing. And when we compare sort of the overall performance of the Q-naive and the Q-conscious solution in this low attrition setting, is the Q-naive algorithm is going to optimize the placement of sites in such a way to maximize the total arrivals, because they're assuming that everyone that arrives is going to get vaccinated. So it kind of makes sense that it's going to place slightly more, it's going to place sites in such a way that you have slightly more total arrivals in the Q-conscious algorithm. But by placing sites in such a way that the sites are more evenly distributed in terms of the number of arrivals, the Q-conscious algorithm results in fewer losses to attrition compared to the Q-naive solution. And for that reason, it's able to slightly increase our expected vaccination coverage. And then if we look at our high attrition system, the results are very similar in that the Q-conscious algorithm places more sites in these highly populous areas and fewer sites in these less populous areas. And when we look at these histograms, one key difference for this histogram compared to the previous histogram is we have a high attrition setting where there's more bulking and reneging, and as a result, the red portions of these bars are higher. And then once again, we see that the Q-conscious algorithm results in a more even distribution in the number of arrivals across sites. And as a result, it has fewer losses to attrition and therefore a slightly higher expected vaccination coverage. And at this point, we've seen for both our low attrition and high attrition settings that Q-conscious optimization results in a relatively modest gain in expected vaccination coverage. But I do want to point out, to sort of round out these main results, that this modest gain does not capture the indirect effects of attrition. And one observation from the health system literature is that patients are more likely to repeatedly patronize a medical practice that has shorter wait times compared to one with longer wait times. This is kind of an intuitive result. It's in line with my own experience waiting in the doctor's office. And in the context of these mass dog vaccination campaigns, long wait times and attrition may not just discourage someone from staying to get vaccinated in the present year. It may discourage their turnout in subsequent campaigns. And this is so important for the setting where we really need to sustain a high vaccination coverage year after year to effectively combat the canine rabies epidemic. Also, there's been a growing body of literature supporting the social contagion of health-related behaviors and participation in public health campaigns. And in our context, there's a potential for a negative cascade if a dog owner who has a bad experience with long queues at a vaccination site tells their friends and family and social network about these long wait times, and they can really discourage turnout across an entire social network. And so that concludes our main results. And now I want to talk about our sensitivity analysis. And the first thing we wanted to do is to see how, so we saw that the Q-conscious algorithm outperformed the Q-naive algorithm. And we wanted to know if that result was sensitive to misspecification of the bulking and reneging parameters. And to do that, we considered 4 hypothetical sets of true bulking and reneging parameters. These low, a combination of low bulking and reneging parameters, high for both bulking and reneging, or combinations of low and high and low bulking and reneging parameters. And for each one of these 4 scenarios, we assess the performance of both the low attrition solution and the high attrition solution. So the low attrition solution is going to be correctly specified for this situation, but it's going to be incorrectly specified for these 3 situations. And sort of the opposite for this high attrition scenario, it's going to be correctly specified here and then incorrectly specified there. And it will give us an opportunity to assess the performance when we have a correctly specified alpha and beta parameters and situations where we don't. And the performance, which will find as the number of dogs vaccinated and the number of dogs lost to attrition, will be assessed using performance with the Q-naive solution as a benchmark. So in the next slides, I'm going to show you the difference in the number of dogs vaccinated between these Q-conscious solutions versus these the Q-naive solution. So here I'm showing the 4 different scenarios that I discussed for the true balking and reneging rates, and what happens when we apply the low attrition solution in this light blue color and the high attrition solution in the slightly darker blue color. And these solid black lines gives the situation where we have correct specification of our balking and reneging parameters. And I'm showing the additional dogs vaccinated beyond the number of dogs vaccinated under that would have been achieved using the Q-naive solution. And the takeaway from this figure is that even when we have misspecification of our alpha and beta parameters, our performance is pretty similar compared to correct specification. And in all scenarios that we considered, either one of these Q-conscious solutions is going to outperform our Q-naive solutions. And a similar thing goes for attrition, that for any Q-conscious solution used, you will result in a reduction in the dogs lost to attrition compared to the Q-naive solution. So in other words, using either one of the Q-conscious solutions is going to minimize losses to attrition compared to the Q-conscious solution, or sorry, the Q-naive solution. And the second sensitivity analysis that we considered is relaxing that assumption of a constant arrival rate. Because we know from field observations that arrivals don't happen at a constant rate. And it really varies depending on the site, and even within the same site on the day, whether you're going to have arrivals that peak sort of in the middle of the day, whether you have a relatively flat rate and then it dips at the end. Sometimes you have this like very sharp peak with a single peak, or sometimes you have sort of this bimodal distribution in your arrivals. And so for this sensitivity analysis, we came up with 4 hypothetical time-varying arrival densities. That's meant to capture some of the variation in the field observations. So we have some unimodal peaks in these first 3 densities, one with a really sort of focused peak, one that's a sort of a wider peak that's skewed right, one that's skewed left, and then we also have a bimodal distribution here as well. And for each one of these time-varying arrival densities, we also considered 2 attrition regimes, whether there's low attrition propensity or high attrition propensity, for a total of 8 scenarios. And once again, we assess the performance of applying either one of our Q-conscious solutions using the Q-naive solution as a benchmark with respect to the number of dogs vaccinated and the number lost to attrition. And here are the results. So these are our 4 time-varying arrival densities under the low attrition setting, and here are the 4 densities under the high attrition settings. And you can see in all 8 scenarios, both Q-conscious solutions outperform the Q-naive solution. So all these bars are positive. And for attrition, we can see that both of these solutions outperform the Q-naive solutions in terms of reducing the number lost to attrition. So from this, we concluded that even in the absence of a constant arrival rate, the use of Q-conscious solutions, even if they were derived under the sort of constant arrival rate assumptions, using those would still be better than not accounting for queuing in your optimization. So in summary, Q-conscious optimization decreased attrition by 9 to 19% and increased vaccination coverage by 1 to 2% compared to optimization that does not account for queuing. And this improvement is due to the fact that Q-conscious optimization favors vaccination site placement with more even distribution of arrivals, which decreases the losses due to queuing. And we found that Q-conscious solutions outperformed Q-naive solutions, even in the presence of misspecification of our queuing parameters or relaxation of the assumption of a constant arrival rate. And from that, we concluded that queuing behaviors, even in the absence of well-specified queuing parameters, should be incorporated into facility location algorithms to better capture real-world dynamics. And finally, I do want to note, you might have noticed that both the low attrition and high attrition settings, our Q-conscious solution yielded an expected vaccination coverage that falls below that WHO PAHO recommended threshold. And what we're aiming to do to meet that gap is to combine our fixed location vaccination sites with door-to-door vaccination teams to target those low vaccination areas. And also, we noted that by placing more sites in populous areas and fewer sites in these less populous areas, which are these peri-urban areas, which in Arequipa tend to be areas that are economically disadvantaged and have fewer resources. And so this is kind of similar to the observations of bias in AI, where our rational approach had this unintentional bias that could harm these already marginalized populations, which is providing impetus for us to really focus our door-to-door campaigns on peri-urban areas to ensure vaccine equity. And that's our ongoing work, is figuring out how to best optimize the routes of our door-to-door campaign so that they can complement the fixed location vaccination sites. And then as sort of my concluding remark is that queuing is a reality that's present in many public health and healthcare contexts, but is not always captured by models. That as modelers, queuing is not always on our radar. And so my question to the audience is, I want you to think about your own model system and whether it would be worth accounting for queuing, because doing so can result in a more effective implementation and improved patient or customer satisfaction. And with that, I want to thank my advisors in the Department of Biostat, Epi and Epidemiology, or Informatics, Ricardo Castillo and Michael Levy, and our collaborator, Maria Reeders, who is an operations researcher and Q theorist at Wharton. And I also want to thank the field team in Peru, who does a great job collecting survey data after the mass vaccination campaigns each year and work in concert with the Ministry of Health to implement the vaccination campaigns. And yeah, with that, I'd be happy to answer questions if we have time.
Great, thank you. Yeah, we do have some time, and a couple of folks have already put forward some questions in the Q&A. So I'm going to just read these questions and we'll go from there. Although actually, if the folks asking would like to unmute and do that, we have a question from Una Pretarius. Una, would you like to just ask your question?
Hi. Thank you so much, Sherrie. That was a really interesting presentation. So I'm a state veterinarian in South Africa and also working in similar resource limited environments, also dealing with rabies outbreaks sporadically. I was just interested to know whether you had considered instead of having the 20 sites active every day or every day of the working week, whether you had considered doing rotational sites where you had more personnel at fewer sites and then cycled through them, say, you know, on Mondays we did this area, Tuesdays we did this area, and in that way the queues would be shorter. Is that something you looked at all?
Yeah, that is something that we're thinking about. So in essence, converting MM1 sites to like MM3, MM4, And there's definitely advantages to doing so. Like you said, you have more vaccinators, so potentially shorter queues. The disadvantage is since everyone's traveling on foot, if we have fewer sites, then potentially people would have to travel even further with their dogs, which is no small feat because from our surveys, we know that many households don't even have a leash for their dogs, so they have to really get creative with bringing their dogs to the vaccination sites.
Yeah, my suggestion wasn't to have fewer sites, just to have them not every day. So, example, if you had five sites in one, you know, because your area is quite small, it's only a few kilometers, right? So, if you had 5 sites, for example, in your peri-urban area that you were discussing, run one of those 5 on a Monday, one on a Tuesday, one on a Wednesday, because these communities very quickly get used to having, if there's a program and it's regular, that they can come to, they know, oh, Monday is the day we can take our dogs to be vaccinated in this area. So there would still be a site close to everyone, and your algorithm would still, pick the best one. But in that way, they would all be catered to, but faster. And I think that your vaccination coverage would increase. Just a theory. What we actually do in South Africa for rabies is we do door-to-door only. And that has had the best results for us, because as you say, the people don't have transport, the people don't have leashes for their dogs. Very often the dogs are aggressive and the people are actually scared of the dogs, so we have to catch the dogs as well, which is always sports. But just something to consider.
That's a great suggestion. We had not thought of that before. Thank you very much.
Pleasure. Good luck.
Great. We have another question here from Idowu Joshua. So I'm going to let you, can you tell us your question? Okay, not hearing a response.
Yes, I can hear you.
Oh, yeah, go ahead. Go ahead.
Yeah,
Yes, go ahead.
Yes, is there a way we can apply this spatial optimization to infectious disease model that requires deterministic solution?
Okay, the audio was
disease model. So yes, I said, is there a way we can apply this spatial optimization to infectious disease model?
So the question here, so the audio wasn't great. Is there a way we can apply spatial optimization to deterministic models to infectious disease model? So,
yeah, I believe so. I believe so.
Doesn't sound like something you've done much work on, though, which is certainly okay.
Yeah, I personally don't have experience with this, but I can imagine how you could incorporate that into modeling. Like if you made some assumptions about what segments of the population would be vaccinated given the placement of a vaccination site, and then I think it would be well suited for like a spatial deterministic infectious disease model.
Great, thank you. We also have Ty Fanarin, I believe, has raised their hand. So please go ahead and ask your question. You're going to have to unmute yourself, I believe. Okay.
Hello.
Yes,
Can you hear me?
Yes.
Yeah, thank you. Thank you very much. That was a nice presentation. My question is, you mentioned that you used MM1, and of course, which is maybe exponential arrival times and exponential service time that follows a person process. So why the use of MM1, and how well does it represent reality?
Yeah, that's a great question. The reason why the MM1 system is so popular is that it gives really nice derivations of sort of the closed form expressions that I showed that we used for our objective function. We have looked at we do have data on the amount of time it takes to vaccinate a dog. And we do see that at least that follows pretty closely an exponential shape. And in terms of the Poisson process, I think it does model well arrivals, because people are arriving sort of independently. They're not sort of communicating with other people to decide when they're coming with their dogs. And in the sensitivity analysis where I was considering a non-constant arrival rate, I was able to do so by sort of assuming a Poisson process, but sort of stepwise function for the arrival rate itself. And I think all of those are decent assumptions.
Oh, thank you.
Great, thank you. Okay, there's a comment here again from a former question. I would appreciate if we can write this model in ODE to qualitatively access the impact of vaccination of the dog population. So you're saying taking the spatial modeling and then modeling an outbreak based on the outcome of your vaccination models would be an interesting thing to possibly pursue.
Okay.
I'm going to throw out a question. I'm curious about some of the more complex dynamics. So, for example, would people reneging have an impact on arrival rates? As in, somebody sees folks leaving the line and they say, "Oh, I'm not going to get on that line." And
Yeah.
so, is there, and obviously that's going to increase the complexity of your models, but do you know of anything like that going on?
That's not something we've observed in the field, though. It's absolutely possible. Yeah, it's a complex behavior that's not captured by our model currently, but I imagine there could be ways, at least for simulations, that we could study it.
Yeah, and I'm also curious about, you mentioned your observational validation. I realize we're just about at the hour, so if people need to go, my apologies, but I want to get this question in. So if you see, you say you've done surveys, is there any sort of detailed observational study or anything more in-depth in a survey to understand the behavior? Because what I'm wondering about is you've got a nice story about that is a plausible model of behavior, but the question of the accuracy of that model of behavior, and it seems like there might be some things that are going on that you wouldn't really be able to get at without either like watching at one of these clinics or interviewing and talking to people very directly about what's going on.
Yeah, we do ask questions about balking and reneging behaviors in the surveys. Though I think the utility of that is limited because people, there's all kinds of like recall bias and stuff like that.
Right.
Something we're more interested in doing is setting up like GoPro cameras at the vaccination site, actually studying directly instances of balking and reneging. Reneging is easier to study, right? But balking, it's sort of like, how far away do we have to sort of capture someone walking towards us and then walking away, and were they really trying to come towards us? So it does get a little bit tricky, but that is something we're interested in doing is mounting sort of cameras at our vaccination sites.
And again, this goes beyond your modeling to the policy, but I just sort of wondered, like, of the sites that you talked about with the timing, most of them were very specific times of day. And so there's at least a hypothesis, given that your placement of sites only accounts for a subset of the problem. Maybe it's just that the sites aren't open at the right hours or something like that. All sorts of complexities there that you're not going to get at without a lot more insight into what's going on. So, all right, we do have one more question from the audience here. If you're willing to stick around for a minute.
Oh, of course, yes, absolutely.
Go ahead, Ona.
Hi, sorry, just also to add to what Harry was saying, we found specifically that in lots of these communities, there are big temporal differences in when people are more likely to come and attend these vaccination campaigns. And the majority was during school holidays, actually, when children who generally were you know, the friendliest with the dogs, the most capable of handling the dogs, especially in these more rural settings as well, when they had time to bring the dogs to come and get vaccinated. So it's a very complex issue that I think just having cameras, you're not going to capture all of that. A lot of it is speaking to locals, finding out about the culture. You know, when do people have free time? Are they more likely to come in the week or on weekends? Who's going to be bringing the animals? Is it adults? Is it children? I think, you know, it's not cut and dry in many of these developing countries, and you need to dig deeper. And unfortunately, that does really increase the complexity of your model, but just something to think about.
No, yeah, these are all great points. I will say I'm stationed here in Philadelphia. We have quite a large team in Peru who are local to the area, and there's a lot of thought that goes into the surveys that are asked each year. I guess another complicating factor for us is, so I'm showing just a single like micro-red little district, but the mass dog vaccination campaigns, it's across, you know, 20 or more of these micro-reds. And then they have to sort of coordinate these 20 vaccinators are sort of, they go from micro-red to micro-red. And it's usually on the weekends. And I imagine weekends were chosen because those would be the times that people have time to bring their dogs to these sites. So yeah, I imagine it's a back and forth between you know, what we've learned from the surveys and what's sort of feasible with the resources and the collaborators that we have at the Ministry of Health, what's possible.
Okay, well, it's a couple minutes after the hour, so I think it's probably a good time to wrap up here. I put Dr. Zhe's email in the chat, so I encourage folks to get in touch with her directly if there are further questions. But I want to thank you for this really nice and interesting talk. It's the first time I think we've heard anything on queuing theory in the MIDAS series, so that's great to hear of another set of tools that people can use in their tool chest for modeling. And so thank you very much. We'll be back at the end of April with another webinar. Kristen, what's the date? Is it the 26th?
Yes, it's the 26th.
Okay, great. We'll hope to see you all then. Thank you so much.